Okay, welcome everybody. It's great to see this room filling up. I was just told by Tadej, the president of ATTD, that it's a bit confusing that the Eversense sign is still up out there from this morning, but I'm glad everybody seemed to have found us. Welcome to dedoc. Welcome to the dedoc symposium, everyone. My name is Bastian Hauck. I am the founder of dedoc, and it is my great honor to be here today. This is the fourth time we do this at ATTD. And this is special and important because the first time we did this was at ATTD 2020, and that was the first time we ever did a symposium at an international conference. It was also the last time we would used to do it for quite a while, because those of you who will have been there in 2020 will remember that the weekend ATTD was closing was the weekend that the COVID pandemic started. And at the end of ATTD, you would see some Italian people, members of ATTD, running to the airport, catching a flight home because they heard of first cases popping up in Milan and Rome, etc. So our first symposium ever was at ATTD, and it was quite a milestone for us at dedoc because for a number of years before, we had done our doc days. And doc days were small, cozy events in the beginning that grew over time. I think the last big one we did was at EASD the year before, 2019, with about 150, 200 participants. But it was mostly people from the community, within the community of people living with diabetes. And it would be some HCPs, some people from industry, some researchers joining, but it was very much the community amongst ourselves. And it wasn't really official in the beginning. It took a while for us to be officially allowed to even enter conferences like these as people living with. And now, a couple of years on, we did the first symposium, we survived the pandemic, we did a number of symposia at ATTD, also at EASD and ISPAT in a virtual format. Then last year, we went back to hybrid, doing virtual and in person. And now it's 2023, it's our fourth symposium, and we are back here. And I want to extend a warm welcome not only to all of you who are here in this room, and I'm very, very glad to see that it's so crowded. I also want to extend a warm welcome to everybody watching virtually, because that is another very important aspect of everything we do at dedoc, be it symposia, be it our virtual doc days these days or other formats. We are streaming this event live not only on the ATTD conference platform, but we are streaming right now live on Facebook, on YouTube, and on our dedoc.org website, because it is important for us that everything we do is accessible and available free of charge to every person living with diabetes, and in fact everybody else in the diabetes online community, wherever they may be in this world. And I would like to thank ATTD for making this huge exception to be able to stream this content live outside of the paywall without the need to register on Facebook, YouTube, and on our website. Having said that, I wanted to keep this short. This is dedoc. This is a platform for people living with diabetes, and one of the things we are most proud of is that we have started the dedoc Voices Scholarship Program, with which, since 2020, we have enabled diabetes advocates from around the globe to join these international conferences. And I would, at this point, like to ask every dedoc voice and the dedoc team to get up, turn around, and say hi so that everybody can see you and give you a round of applause. In total, you will see we have a group of more than 20 dedoc voices. We have a group of more than 20 dedoc voices who are attending in person, and I think 25 to 27 who are attending virtually. Unfortunately, for the first time in our short history, we've had a number of issues with visa to the Schengen area. So there's a couple of dedoc voices from India, Pakistan, and the African continent who unfortunately we would have liked to support to come here in person. They couldn't make it, but they are out there. So you and all the other virtual voices, welcome, and everybody else watching, it's great to have you here. What we wish you knew and why will be the title of our symposium. What we the people living with diabetes wish that you, HCPs, researchers, and members of the industry, what we wish you knew and why. Because ATTD is so much focused on technology, we decided to keep this symposium focused on the lived experience perspective on technology as well. And because some of you might know that we have just wrapped up the OPEN project, a 4-year research project funded by the European Commission. And we had a big closing conference this morning around that. It went for several hours. So we have decided to keep it focused on that, to bring parts of that conference here to ATTD as well. So it might be a bit repetitious for those of you who have been there already, but we have a different group of speakers with different perspectives on what we have been doing and how DIY APS has been perceived in the WeAreNotWaiting movement. You can see the agenda for today. I will introduce all the speakers once we get there, but for now, it is my great honor to welcome Tadej Battellino. You all know him, the president here at ATTD, for his words of welcome. And again, Tadej, thank you for allowing us to be here 4th time in a row.
First, thank you very much for having me in your community. It's not allowing, it's actually a privilege that you decided to come. When I started working with people with diabetes 35 years ago, my old professor, who was a founder of ISPAT, together with Professor Lestrade in Paris, told me that the only way to treat diabetes successfully is to collaborate with people with diabetes and their families. And at that time, we didn't have technology. We had very simple insulins and, very simple measurement methods. But the message is the same, and it's only natural to ask people with diabetes what they like, what works for them in order to be successful. If we go this way, whatever the technology or treatment we use, we are much more likely to be successful, and success of people with diabetes is the only thing that really counts. So I feel privileged that you're here with us. We are listening. And thank you for helping us, physicians, pushing what's needed to be pushed in order to improve lives of you and of this large community out there that actually has to live with this, I think, rather difficult disease. Have a very nice symposium, and thank you for having me here.
Thank you today, and again, thank you for inviting us year after year. Thank you for having us. When we had this conversation 4.5, 5 years ago for the first time, we were asking you if we could have a seat at the table, and you said yes, and Moshe said yes, and that's why we came. And now it seems, with a room like this full of people, we are the table, at least for the next couple of minutes. Thank you very much. WeAreNotWaiting was the battle cry of the DIY APS community. Nothing about us without us is the battle cry of DDoc and the Diabetes Online community. And with that, I would like to call our first speaker, Katarina Braune, who will talk about the OPEN project, what has been achieved, patient-driven research. We keep it very simple at DDoc. Speakers will introduce themselves. Suffice it to say, Katarina is working here in Berlin at Charité. She's also the head at DDoc of all medical affairs, because it's good to have a doctor amongst the patient-led, patient-driven community, and she was in charge of leading one of the most important parts of research in the OPEN project. Katarina, tell us all about it. Thank you for being here.
Thanks, Bastian. We keep repeating this joke that OPEN is closing today a number of times. So my name is Kati. I'm co-founder of OPEN, pediatrician, diabetologist, living with type 1 for more than 20 years. And I'm trying to wrap up 4 years of research in 10 minutes, which is quite challenging. We are OPEN. We are a patient-led project funded by the European Union, the Berlin Institute of Health, and we are at 9 different institutions spread all over the globe. And in the last 4 years, we have been working scientifically on the topic of open source AID and the WeAreNot community as a phenomenon from different angles. So we were interested in the clinical outcomes that people experience, but also the changes open source AID has had on their quality of life and sleep quality and lived experiences. We've also looked into technical aspects such as machine learning and the user experience, and then we also looked into barriers to scale up, so hopefully that in the future more people can benefit from AID as an innovation. And this is the technical backbone we had in place for the open project. So we are completely open source in all of the scientific tools we generate, but also in the data. People could sign up and anonymously donate their data. It's been made available to other researchers as well and will be in the future. And just calculating with a community of roughly 10,000 people plus using open source AID, up until today, we have more than 1 billion hours of experience, of real-world experience with open source AID. I think that's quite remarkable. And who joined Opens research in the end? Over the time, it was you guys, more than 1,500 participants from more than 40 countries. But the common language we all speak is diabetes. And here are some of the clinical outcome data from the people that participated. So the hemoglobin A1C, our long-term marker in diabetes therapy, went down by open source AID use almost 1 percentage point. And more importantly, this improvement was independently of sex and age. So it did not matter if you're a man, a woman, or diverse, or how old you were, everyone had success using this. And this is also reflected by the time and range that people experienced. So beforehand, on average, people spend 14 hours within reference range, and this went up to 19 hours per day. So, of course, there are still a couple like spikes after meals and the occasional hypo, but the majority of the day, people would actually spend in range with automated insulin delivery DIY'd. And we also compared real-world evidence of open source AID users with people on commercial AIDs. And we did not find a dramatic difference. So these are studies on children, on adolescents and adults, and people more or less experience the same benefits. We also looked into quality of life, so we used a battery of validated questionnaires on diabetes-related quality of life, on fear of hypoglycemia, on treatment satisfaction, on sleep quality, and so forth. And pretty much every measure we looked at was significantly improved between the user group and the non-users who were part of the WeAreNotWaiting community. But our research didn't stop there, so we were interested in why people initiated using open source AID, and we read through thousands of your stories. It was such a pleasure to read them. Here you just see two word clouds with the most frequently used words, and the one on the left is the caregiver's one. I think that something that clearly stands out is sleep. So this is what they got back from open source AID. The parents in the room will know how to appreciate that. And the story is super long. We have endless tables, but I brought my favorite quotes along. And this one is from a caregiver from the UK, and they said, "If I could give my pancreas to my son, I would. This is the next best available option." And then another one, "This is for my wife. She wants me to live forever. This is as close as I can do for her." And this was supposed to be a crying emoji of me analyzing your data, but not showing. Then our technical team was working on big data, and we found out, we built scripts on how to deduplicate your data, on how to analyze glycemic variability and so forth. And right now, we're just beginning to look into machine learning aspects. So I won't have the time to go into detail here, but we're also comparing accuracy of different machine learning algorithms with computing costs, so we can make decisions on what the trade-off is. And our goal is to get longer predictions than just a couple of hours, as these systems are doing now, for actually days or weeks, and then be able to personalize the systems based on your priorities, because not everyone is using diabetes technology the same way. People have different priorities, whether it is hypoprevention, meal management, and then also, right now there's no adaptation to the menstrual cycle implemented at all. We also looked at barriers to scale, so not only DIY, but also DIY not, and we found that sourcing components and associated costs with them were the main barrier. So as long as people don't have access to affordable insulin pumps and CGM, this prevents them from going on an AID. People were also quite worried about limited support from their HCPs. So this goes to all of the HCPs in the room. Please don't let them down. And then low self-perceived levels of tech literacy were also a big point. But then we read your stories, and many people said they were actually able to overcome that barrier by working with the community and getting help from them. So why did we need professional guidance, and why did we tackle this in open as well? Well, someone said, my diabetes doc said, officially I cannot approve of what you're doing, but if I were in your situation, I'd do the same. And then another person said, because my doctor is not legally allowed to support my DIY adventure, we pretty much keep it at a don't ask, don't tell. So if you ask me, this is risky and the opposite of safety. And this is why we came up with an international consensus statement, co-led by Sufyan Hussain from London, co-led by Rehan Lal from Stanford, and we involved 44 healthcare professionals from all different fields of medicine, including diabetes educators, psychologists, and nurses, and also 4 legal experts on the topic of device regulation. And this consensus got validated by professional diabetes associations such as ISPAD, ADCES, and the IDF. And if you're interested, you can read it in The Lancet. It was published in the 100 Years of Insulin special issue last year. So people, the evidence is out there. There are so many studies on open source AID. We have studied this thing in silico, in swine, in the real world, in qualitative research, in systematic reviews, and now even in RCTs. So it's out there. Is our mission accomplished? Yes and no. I think now's the time to closer look into gender, age, and other user characteristics under real-world conditions, and on user behavior, because again, not everyone is using diabetes technology the same way, and one size does not fit all. So now's the time to customize and improve AID for different user groups. And Dana and I are hopefully going to continue that, so shout out to her. And it's a wrap. That was open in 10 minutes. Happy to take your questions later.
Thank you, Katarina. Thank you for wrapping up 4 years of research and the Openness Closing Conference from this morning in 10 minutes. We don't want to dwell into the details of what OpenWatch was doing, but I think you saw that it's been quite impressive. The important thing from our perspective is that most of the research done, most of the people involved in this EU-funded project were people living with diabetes. There were hybrids, people like Katarina and others who live with diabetes and are HCPs, researchers in their official life, but there were many, many, many people working on it, full-time, half-time, volunteering. It was truly patient, user-driven, and I think that was the most special aspect of this 4-year research project of all. What we will be doing now, we have 3 dedoc voices now who will give different perspectives and opinions on what they have been contributing, how they have been living with DIY solutions, where they have been doing research, what they have heard during the Openness Closing Wrap-Up Conference, 3 different perspectives on DIYAPS, the WeAreNotWaiting community. And we're starting with our dedoc voice from the Netherlands, Minou van Os, who has also been doing quite a bit of research, and she will be reflecting on this question that Katarina was putting out there at the very end. Where are we with the DIY community now that commercial solutions in closed loop are on the market? Are we at a point where we say mission accomplished, or are there new challenges out there? Minou, thank you for joining us.
Yes, thank you, Bastian, for your great announcement. And I would also like to start off with a word of thank you, because I'm incredibly grateful to be able to stand here today. This is my first time to be attending ATTD in person, and also my first time to be attending as a DDoc voice on a diabetes conference, and also the first time I'll be speaking as a DDoc voice on this stage. So that's incredibly exciting. And then, yeah, maybe it's good to introduce myself. So my name is Minou. I've lived with diabetes for over 3 years now, and I've been using an open source APS myself for more than 2.5 years. Other than that, I have multiple other roles. You can see all of my badges here that I collected today at the Open Closing Conference. I'm also active in the field of medical psychology, where I'm doing research. I'm currently pursuing a PhD, and I'm also conducting research within the field of open source APS. My main research focus is on the dual perspective of people with diabetes and healthcare professionals. So I could be talking here a lot about research, but you've heard all about the Open Project just from Katarina. So today I'll be sharing my personal story with all of you. So I was diagnosed with type 1 diabetes in October 2019. And I think all of you in this audience who have type 1 diabetes or another type of diabetes themselves can know what it's like to think back to that day and to feel like it feels almost like yesterday, and you can still feel the feeling you felt on that day. Your whole life gets turned upside down. It's like a roller coaster that you end up in without wanting to ride it. It's really overwhelming, and although it could be quite scary at some times to get to live with this new diagnosis, I tried to find a way to make my life with diabetes just a little bit easier. I tried to look for the best solution for me to make my life easier and to be able to live my life with diabetes instead of the other way around. And I started looking out for, okay, what could be the best solution for me to live with this condition? And then, of course, the first place you head to would be your healthcare team, because, of course, they are the ones with the knowledge. So then you ask them, okay, what is available to me? What solutions are there for me to make my life easier? And they told me, okay, we have this website, and you can have a look and fill in your preferences, and at the end, it will pop up what's the best system for you. So the combination of an insulin pump and a glucose sensor. So I thought, okay, let's see what's my solution for my problem, this new condition. So I filled in this tool, and then I was actually a little bit sad because it told me, okay, nothing fits your preferences. So this is actually where my journey began, because, well, I talked to my diabetes team, and they, of course, told me, yeah, you are right, there is nothing that fits your preferences perfectly. But I actually wasn't satisfied with that answer. So I started looking, where can I find more information? And I headed out to the diabetes online community. I went to one of the Facebook groups available, and I just posed a question, well, what should I do? There's nothing that fits my needs. And then many helpful comments came up from all kinds of people with diabetes, which were very, very helpful in my situation, of course. And there was one of them from a person who pointed me at the existence of the Looped Facebook group. And for me, it felt like this was the first spark. And sometimes all you need is just one spark to set something bigger off in your life. So then, flash forward to now. Eventually, I decided to use an open source APS, as I've already told you previously, and I've never regretted that for 1 second. It has been the best choice I've made in my diabetes career, so to say. And that's not only true for me, but also for all of the others living with diabetes. So many more options have also become available now since 2019, because in 2019, when I was finding out the best system for me, there was only one closed-loop system available at that point. And now there are so many more options. If I have to choose a new system now, I have lots of things to choose from. Not only open source, but also commercial. And WeAreNotWaiting and the open mindset has been super important in speeding up this process, so also speeding up the process at the industry side. And this would never have been possible without Dana Lewis, who started all of this, and of course all of the other heroes that are active in the do-it-yourself and WeAreNotWaiting community. And it's good to know that the WeAreNotWaiting movement would not exist if there would have been perfect options for us available. WeAreNotWaiting exists because those options aren't perfect and do not fit our preferences perfectly. And this is a good example to give of this is that Dana Lewis started all of it because she didn't wake up from her alarms that her CGM gave herself. And the same was true for me in a sense, because I couldn't find a system that was perfect for me, so I started looking what else can I do? And even though living with diabetes has become a bit easier for me, now I'm using an open source system, diabetes still is a struggle. And every day I have moments when diabetes is in my way. So every day I'm also still looking for ways to make my life with diabetes a little bit easier. And then this is just a matter of choice, which is also very important. But there are also lots of people for who diabetes technology is not available, or even insulin might not be available. So this brings me back to the original question. Mission accomplished, or what's next? I think with my story I've illustrated that the mission has definitely not been accomplished yet. There have been great steps in the right direction. And I definitely think that from my interviews with healthcare professionals and people with diabetes, it shows that many people with diabetes are still very fond of open source APS. I myself would never want to switch, or maybe someday, but today I would never want to switch to a commercial system. And also healthcare professionals in my interview study expect the systems to remain used in the future. So there have been great steps so far. And I think what I feel like is that WeAreNotWaiting is living in all of us. We all take small steps in the right direction, but together we can make a big change. And that's why I hope to say, what's next? Let's all continue to not keep waiting.
Thank you, Minou, for that personal comment and perspective and story. A few housekeeping notes. I see there's a number of people waiting in the back. There's a full first front row empty and a couple of seats that are spread in between, so feel welcome to just come forward if you don't want to stand, or if you want to stand, keep on doing that. Another thing you will have already noticed, we do not follow the usual symposium style where we have a presentation and then questions and the presentation and then questions. Instead, if you have questions, please keep them, write them down, or send them through the ATTD app. Or if you're following on Facebook, you can put your questions in the Facebook comments. They will all arrive on my cell phone and on this iPad we have up here. We will be having all the speakers up here for an extended Q&A and panel discussion setting right after we finish. So keep your questions either in the room for later when you can come up to the microphones, or post them through the ATTD app or on the Facebook Live in the comments. With that, Minou, you gave your perspective on mission accomplished versus what's next. My own perspective when we started the Open project has always been that if the Open project and the research we do in the WeAreNotWaiting community on the DIY solutions leads to commercial industry players coming forward and bringing these closed loop systems into the market, then for me personally, I would consider this mission accomplished. So if I stick true to what I said 4 or 5 years ago, from my perspective, then I would have to say I think we've contributed to coming to a place where we are at mission accomplished in some degree, because there are so many great commercial systems out there these days, and it moved quite quickly, and I am personally using one of them, and I'm actually very happy with that. But there's other perspectives, and Dawn, you will be presenting research that you have done, again, from a user perspective on some other corners where commercial systems will probably not go anytime soon. You will introduce yourself, what you've been working on these last years. And I think it is great to see once again that when there is unmet needs felt by people living with diabetes, it's the community of people living with diabetes stepping in, bringing these forward, figuring out solutions or research, and we will hear more about this from Dawn herself. Dawn from Northern Ireland, our dedoc voice. Thank you for being here.
Hello, so my name is Dawn Adams. I live in Northern Ireland and I was diagnosed with type 1 diabetes 30 years ago. And I work as a midwife, that's my primary career, and I also work as a PhD researcher at Ulster University, now in their Belfast campus. I'm very interested in the whole concept of citizen science. As someone who uses Android APS, and has done so for 3 years, I found more and more that while Open has come to a close, for those of us using the systems, the advice, the information that we have, has suddenly thrown a whole new range, raft of questions at us. There are things that we want to know, things we want to find out. And citizen science is the involvement of the public in scientific research, whether community-driven research or global investigations. The Citizen Science Association unites expertise from educators, scientists, data managers, and others to power citizen science. So why does this matter? When many of us who've lived with diabetes for more than 25 years or more were diagnosed, the expectation was that we wouldn't live long, healthy lives. I keep having flashbacks to the day that I was admitted to the hospital with high blood glucose levels in a state of DKA. And what I remember most was 2 days later a conversation with my consultant who said, "You probably won't get pregnant. And if you do, you probably won't live long enough to see the menopause. You'll probably be dead by the time you're 40 or 45. That was the reality. I did make it past all of those targets. I did come through that, in part because of the work of the St. Vincent Declaration and the Diabetes Control and Complications trials. Their results were aspirational. They set a very high bar, but as my mother would have said, you saw targets and you always did your best to beat them. If somebody told you you couldn't, you went out of your way to prove them wrong. One of the things that we were doing back then was working with insulin vials, syringes, glucometers that took 2 minutes to give a reading, and we'd no peer support. We were working completely independently. Changes then started to come about as we accessed education programs, glucometers, insulin pumps, intermittent continuous glucose monitors and continuous glucose monitors, peer support and DIY APS. As I've said, I've come through the pregnancy stage. I've now hit that menopause stage in life, and that has thrown up so many questions. Katarina referenced that earlier today in her talk at the Open Project. It was referenced by other speakers earlier on today as well. What we started to realize, once we had continuous glucose data, once we were able to look at insulin profiles, once we were able to look at insulin sensitivity, we noticed that not only did a deficit of insulin being manufactured by our bodies have an impact on how we felt, how we thought, how we moved, how we perceived things. A deficit of estrogen, a deficit of progesterone, a deficit of testosterone also had a significant impact. And no matter how hard we tried, it didn't matter what we ate, it didn't matter how much we exercised, it didn't matter how much time we invested into our diabetes care, but we started to see that we were failing significantly. One of the graphs that was shown at the Open this morning was to do with women and men's profiles run parallel to each other throughout different points in the day. And it's noticeable that women's profiles ran ever so slightly higher. They never seem to run below what a male profile runs at, but certainly they run slightly higher. And that was a conversation that was opened up amongst women who were using DIY APS systems of whatever sort. So with the data, we started to get some power. We started to see how this power was changing, how biology was impacting it, how physiology was affected by it, and how the interactions with diabetes technology continually changed. They were never in a state of constant, it was always in a state of flux. On the screen, you'll see an example of a logbook from one of the Night Scout sites. A number of us got together and we started asking questions in a much more public forum. We were able to hold an online Facebook group meeting for women from right across Europe about menopause and perimenopause, women with type 1 diabetes. So the conversations that had been rumbling quietly in the background about hormones, fertility, insulin resistance, and the sense of personal failure suddenly became much more mainstream. When menopause took centre stage, we started to have questions and we were happy to voice those questions. A number of those examples are up on the screen in front of you there. We pulled together and decided to share our data. We downloaded data from Night Scout. We sent the data to a colleague who works in research, and we were able to validate questions and concerns that we had within the type 1 community as a population moving through perimenopause into menopause. We were able to take a data set from one individual who pre-HRT, hormone replacement therapy, and post-hormone replacement therapy initiation. We were able to take information from a similarly matched individual who had not decided to use HRT at that point in time. And we were able to show a change in the insulin sensitivity, in the amount of insulin required by the person who had gone from no hormone replacement therapy into hormone replacement therapy. And we had as our comparison the person who hadn't taken any hormone replacement therapy, apart from insulin. Obviously, it is a hormone. The paper was published and was presented at the 9th International Electronic Conference on Sensors and Applications in November last year. It was quite an achievement to have this topic being presented at an international global physics conference, and it received a very warm welcome with a lot of feedback from the symposium directors, from those participating in online discussions as well. As a result of that work, collaborative work from within the community, a citizen science project, we were able to find out that people with diabetes are curious, they're observant, they're very interested, they're very invested, and they're here for the long game. And I think that was echoed very strongly today in the open sessions as well. And as Tadej has also said earlier on, you have to include people living with diabetes in the management of diabetes. If you don't, you're not going to fill in those blanks, you're not going to fill in those gaps. The research that you undertake isn't necessarily going to translate well into real-life situations. And as a researcher, if you're not researching to improve the quality of lives of people around you, what are you researching for? So why does this matter? And what do we, as people living with diabetes, want you to know? Many of us have already exceeded the expectations of clinicians who guided us in the early days following our diagnosis. We want those who come behind us to have ownership of the knowledge we are helping to create so that they can live even better lives than the lives that we've lived. If we ask you, our consultants and healthcare professionals, questions, it's because we want to know the answers. We want to know what you can do to guide and support us as we try and traverse life with a complicated condition. And if you can't answer the questions, we'll find a way to answer those questions ourselves. There is a lot of power within the diabetes community, and I think in this instance we have harnessed the power, we've given you some research, we've opened a door, and we're more than happy to support you as you pursue this topic for future reference. Thank you for listening.
Thank you, Dawn. I think that was, and I hope you all agree, that was really powerful. And I hope that to all the healthcare professionals in the room, that doesn't sound like a threat that we will find the answers ourselves. It is meant as we want to collaborate, we want to work together with you, with research, with industry, but we always ask to be included, and we have become more, you call it more powerful, but also more self-aware of what we can do. And if that diabetes online community and the people living with diabetes are enabled together with technology that is free of charge, like the DIY APS community, and that data comes together, we can find solutions and work on topics that maybe for some official researchers or industry are not so important yet or do not take center stage yet. But that has been said about many things in the past that now are center stage. So let's see where we go with this. We said we will have a panel discussion, and it's coming up after our last presentation. It's interesting to see that on our Facebook live stream, And through the app, we're already getting first comments and questions, and many of them circle around access to this kind of technology. Now, you all know that DIY technology, at least the algorithm, is available for free, but it doesn't really help you much if you don't have the hardware, meaning the pumps, the supplies, or even the insulin, the test strips, etc., to be able to use it. As dedoc, we have expanded quite significantly over the last couple of years, specifically during the pandemic when we turned virtual and were able to reach more and more advocates in countries that we have not reached before. This goes specifically for big countries like India and Pakistan, but also for all of the African continent. And access there takes a very different, or the discussion around access is a very different one than the one we are used to here in the Western world. It is my great honor to now introduce Hamidah Nabakka from Uganda. It's her first time at an international conference like this. We are honored to have you here. She will talk about her perspective on what it means to have access or not have access to diabetes technology. Please help me welcome Hamidah Nabakka from Uganda. The stage is yours.
Good evening, ladies and gentlemen. My name is Hamidah Nabakka. I'm a type 1 warrior from Uganda, Africa. I have been living with diabetes for the last 17 years. I work with the Sonia Nabeta Foundation, and below is my presentation. We believe in an Africa where children with type 1 diabetes have an equal chance at long, healthy, gainful, and productive lives. In Uganda, children with type 1 diabetes are at high risk of suboptimal health outcomes due to a variety of reasons, including low type 1 diabetes capacity, prohibits costs of essential medicines, and the failure to address the social determinants of health. Some of the social determinants of health includes poverty, social barriers, food insecurity, literacy to education, and optimal type 1 diabetes outcomes require carb counting, adjustable insulin dosages, but how when you can't read or count? That is stress. Stigma in communities puts warriors at risk, and that is stress. Schools discriminations against warriors, that is stress. Poverty is endemic and exhibits challenges with type 1 diabetes. How can you inject when you have no food? How can you find transport to clinic? That is stress. Moreover, available technologies like CGMs and insulin pumps require electricity and the internet, which are a luxury in low-income resource countries. Abject poverty, illiteracy, access to electricity, access to the internet, access to healthcare facilities, that's a luxury. In 2005, the whole of Africa had an international internet bandwidth than Luxembourg, a country the size of the state of Rhode Island. Africa's connectivity gap. Can a map tell the story? 2 decades later, despite progress, much of Africa is still unconnected, and large population cannot fully realize the benefits of connectivity. Pictures of some of our warriors in Uganda. And I take you through some of the stories of the warriors that we serve from very low income resource backgrounds. In Amolata, Uganda, 14-year-old, diagnosed in December 2017, born to a single mother that earns up to 5,000 Ugandan shillings, that's approximately $1.5 US. Selling tomatoes, father is deceased, 6 children in the family, all under the age of 15, 2 nights or week meals are less, anxious about resentment from siblings as mother prioritizes his food needs, fear of sleeping and dying of hypoglycemia, A1C 12.3%. Chiwamba village, Lilongwe, Malawi, born to an unemployed mother that raises 5 children. Father is a builder, diagnosed in January 2017, not in school and speaks no English. Travels almost 6 hours round trip to get medical supplies. Identified as one of the at-risk kids at Camp Tikoza, which was held in Malawi in 2019. Faints once a week, has night lows every day. Taking you to Ghana, where we have one of our warriors named Kumasi and Ankwame, diagnosed in December 2017, born to a polio-affected cobbler and a petty trader, earning a combined income of approximately $2.575 a day, frequently hospitalized and prohibited T1D cost forced the family of 5 into bankruptcy and homelessness. In June 2019, warriors enlisted at an orphanage, abstained from school due to T1D, currently not in school. About 17 years ago, when I was diagnosed with type 1 diabetes, I was misdiagnosed with malaria, sickle cell, anemia, went into DKA, coma, and I was subjected to herbal remedies in search for a cure. However, well-intentioned, struggled with loneliness and depression, and by the age of 17, I was out of school as my family had exhausted their financial resources. I was fortunate enough to be part of a SEA Games study in Uganda in 2022, which greatly improved my glycemic control. However, with load shedding, electricity to charge, it was unpredictable. I needed to get to the clinic in order to access the data. I had to hide it for fear of security. Once my participation in the study was over, I could not afford to continue with it. Improvements in infrastructure, for example, electricity and internet access, low cost of technology, for example, technology that is compatible with basic feature phones, enabling regulatory environment, subsidizing of costs of medical technology can be the future in Africa. We look forward to a world where children with type 1 diabetes have an access to productive and gainful lives. As the Senior Beta Foundation, the organization that I work with, and currently as an advocate, I have a YouTube channel where I'm going to be focusing on bringing the world closer to what it means to live with type 1 diabetes in Africa. And type 1 diabetes should never get in the way of a child's dream. Thank you, DIDOC Voices, and everyone.
Hamidah, thank you for sharing your story, your foundation's work, and also the stories of some of the others. At DIDOC, we always believe that these discussions around access, as far away as they seem in our normal lives here, are very important to bring back to conferences like this, not only because we then sit there and say, oh yes, that's a problem, and then kind of discard it saying, yeah, but that's not something we maybe can do something about it right now. Because some of if we translate some of the things we hear from Hamidah here, some of these things are really important and we can do something about it. And this goes specifically to people working in industry and research. And it's something that we may not be aware of, but when we hear Hamidah talk about load shedding, meaning that electricity is cut for many, many hours a day, then if you translate that back to development of diabetes devices, it means that these devices better have batteries that last for extended periods of time without needing recharge. And if we hear about Wi-Fi access basically not being available in most of the villages of rural Africa, it means that some of the devices like follow-apps, etc., need to find other ways of being accessible in terms of for someone like you being able to access the data without having to rely on Wi-Fi, because Wi-Fi will not be there for days or even weeks. And it's, I think, something that many people working in industry and research will not have at the forefront of their minds when doing studies and developing technology, but we should be able to hear these voices and make these technologies more accessible, not only on the DIY front, but on the other front as well, hoping that they will eventually find their ways into low-income countries as well. There are a number of comments right now. There's one that I would like to read. It comes from Tino Tsikiti. He is one of our dedoc voices. He lives in Zimbabwe. He's following live right now. And I'll make it a bit shorter, but he says, in many of our low-income countries, chronic care services for diabetes and other severe conditions are only available at referral hospitals in major cities, making treatment both inaccessible and unaffordable for the rural poor population, for instance, in Zimbabwe and Mozambique, etc. As a result, many poor children and young adults go without treatment for conditions that almost always lead to premature death. One study found that life expectancy for children with type 1 diabetes in these settings is less than 1 year after diagnosis in much of sub-Saharan Africa. Less than 1 year after diagnosis. I think we do need to let this sink in and think about this and compare it to our almost spoiled realities here. I've lived with diabetes for over 25 years now. And some of you in here in the audience and up here, and then even amongst our dedoc voices, have lived with diabetes for way more than 60 years. Martin, I'm looking at you. Compare that. Now, I am handing over to Renza Scibilia, who will facilitate a Q&A plus panel discussion on some of the things we've heard about DIY, about the personal story of Minou, about the research of Dawn, and about the access discussions and the situation. And you are all welcome to come forward with comments, with questions, with own perspectives to the microphones up here. You're also, as I said, welcome to ask questions through the ATTD app or on our Facebook comments, and I will throw them in as they come.
Yeah, I'll send them straight to my phone. Hi, everybody. I'm so thrilled to be here. And I'm thrilled that I'm looking out to an absolutely packed hall and a sea of faces. So thank you so much for being here. I would ask everybody to consider throughout the remainder of this really important and crucial conference to consider things through the lens of people who are not necessarily going to be accessing easily or at all the latest shiny gadgets. It's something that I know that I'm guilty of. I come from Australia. We last year celebrated and continue to celebrate CGM for all people with type 1 diabetes. The only requirement is that you have type 1 diabetes and then you are eligible. There's no further hoops that we must jump through. It's too easy for us to take that for granted and to think, well, this is the reality for everyone with diabetes. It's not the reality for everyone with diabetes in Australia, even with that, but certainly around the globe. So throughout this week, as you are listening to talks about the latest and greatest in technologies, and we absolutely should be celebrating that, ask about what's being done when it comes to access so that we can level the playing field as much as we possibly can when it comes to people living with diabetes around the world. Now, I get to ask questions, but I always say, please make me do as little work as possible by coming up to the microphones and asking questions. You've got an incredibly dynamic panel here who would be very happy to ask your questions. Eritrea, you can come right here. You can just walk right there. In fact, I'm going to let you ask the first question. Could you please identify yourself, tell us who you are, where you're from, and ask your question to whoever you would like to do that.
Hi, DDoc friends. I'm Eritrea Musa. I work at the DiaTribe Foundation as a social media manager. I also co-host Diabetics Doing Things. My question is for Hamidah. First of all, as an African person, I'm so happy to see you here. Thank you for being here and representing Uganda. For those of us who are not too familiar with the Sonia Nabakka Foundation, what can we as people with diabetes and HCPs do to support you and to help the people in Uganda?
Are the microphones on? You might just need to tap.
Thank you so much. The Sonia Nabakka Foundation is a non-profit organization that specializes specifically about children living with type 1 diabetes in sub-Saharan African countries, and you can visit their website, which is available, www.thesonianabakkafoundation.org, or you can check them out on their Instagram, Facebook, or Twitter. Yes, we have quite a number of projects where we reach out to our warriors in Uganda, and for anyone who would like to collaborate or to reach out to the foundation, they have their email addresses and their websites, and there is an option to donate.
And if there are people on social media, as I know there are in this room, share details of the foundation. Dawn, I want to ask you a question to start with, if that's all right now. I'm delighted to see that there is so much effort or a lot of effort to start with, about diabetes and menopause. 21 years ago when I started working in diabetes advocacy, there wasn't all that much information that was really aimed at people with diabetes who were planning pregnancies, and suddenly there was a community groundswell that made that happen. Is that what we're seeing now? And is it the same people who 25 years ago were desperate for information about diabetes and pregnancy? Is that the cycle of what happens in our community?
I think that is probably the population that you're looking at. As I said in the talk, whenever I have 4 sons, so I had 4 pregnancies, which resulted in live births. Each pregnancy I was told I was in a study group. I was in Manderson et al.'s pre and post prandial glucose study from I was co-opted into it in 1997, it was published in 2004. I was also in the diabetes and preeclampsia intervention trial, so I kind of thought, in my naivety, as did many of my friends who are now in a menopause mothers WhatsApp group with me, that whenever you went through various life stages with diabetes, you were suddenly roped in to research by your consultant. You didn't have like a get-out clause. You were there. You had data. They were going to harvest it. They were going to publish 1 million papers. And people coming behind you would suddenly know all these amazing, wonderful things, and that would just pave the way ahead for people coming in our wake, as I said. So yeah, I think whenever a number of us started going through menopause, perimenopause, and realizing that there were differences, we started asking questions. And when I asked my consultant in 2015 what information she could give me as someone living with type 1 diabetes about menopause, her initial response was, "You're a midwife, you know this stuff." Okay, and then she directed me to an information leaflet. It was an A4 page, folded in 3, and it said, "Check your blood glucose levels more regularly."
Isn't that the answer to everything? Like, I feel like that's just the answer to everything with diabetes, is just check your glucose levels more.
Check your blood glucose levels more regularly. By 2016, whenever I was using Freestyle Libre, I went, but it's checking for me. If I scan 3 times, if I scan every 8 hours, I get 24 hours worth of data. What else am I meant to do? You know, what am I meant to find? And that was where the conversations with others within the diabetes community started to come from, because it was actually really frustrating. When you go into an appointment with someone who is meant to be the expert in your condition, with someone who you've been trusting to get you through pregnancies safely, to get you through breastfeeding safely, to get you to your next pregnancy safely. And you ask, okay, now that I've come past that phase of my life, what happens now? To be met with, yeah, check your blood glucose levels more regularly. Yeah, you work in a profession which basically knows more about this stuff than I ever will. It felt quite disheartening. But it was even more disheartening for women who didn't have the midwifery knowledge, who didn't have access to Libres. And that was where we built up a support network in the background. And I am so grateful, so thankful to that support network, because we have managed to get a research paper out there as a proof of concept study. And I really do hope that other people now feel that they can take it, that they can run with it. And because our contact details are very widely available in social media, we're not hard to find, and we're more than happy to be involved in more detailed, more in-depth research as well.
Thanks, Dawn. And we're going to come back to talking about just that power of community. And I know that we kept talking about diabetes online community earlier. It's not just online communities. Communities don't have to only be online. It is however people with diabetes congregate, whether that be in real life or on Twitter. Bastian, you've got some comments there, I think, that you want to share.
So
you're not on. Yeah.
I'd say we stick to that because there is a question to you, Dawn and Katarina. You've partly answered it already, but it's by Mary Murphy from the ATTD app, so someone who's following ATTD virtually. What can us women, you women with diabetes, do to help highlight the issues we have managing our blood sugars and help ourselves? Do you want to go first, or Katarina, do you want to jump in?
Sure. Thanks, Mary, for that important question. I think the first step is awareness building, because although half of the population with diabetes are women, this is not well researched enough. There's very little evidence published outside the context of pregnancy about women with diabetes. So bring it up in the talks with your provider, ask these questions, make people aware of that this is an under-researched area. It might not be something that is well funded, but that can change through awareness. And keep an eye out, because we are for sure going to look into this aspect with Open. There will be the Type 2 period project and so forth. So hopefully that's going to change. Do you want to add in?
Yeah, just to add to that, no matter which country you live in, you do have diabetes organisations which are there to support you and to help you. And they're meant to be patient-led groups. They're meant to be able to reach out and answer or help to provide the answers that you're looking for. So don't be afraid to approach them. If there is something that's a burning issue with you and you don't want to approach them as a lone individual, do find others within your community who are more than happy to band with you, because there's power in numbers, there's strength in numbers. One of the things that I did say at the physics conference was quantitative data carries a heck of a lot more power than qualitative data whenever it comes to medicine. Whenever you're using any of the open APS systems, there is so much quantitative data in that, it's very hard to argue with it.
Yeah, and I think it's also not just accepting the check your blood glucose more frequently. And I know that diabetes is such a hard gig, and to have to add on top of that we've got to go in and fight to actually be heard and for our concerns actually to be taken seriously is really tough. But that's where community, I think, is really powerful, because if you can point to something to say, this isn't just me, there is a proof of concept, whatever it might be, and highlight that there is data, suddenly those stories that can often be really easily dismissed have got that evidence behind them. I always talk about hearts and minds. It's always about, you know, hearts and minds, and when we bring those things together, we're a lot harder to ignore and to be ignored. So I always think that that's really critical as well. Is there something, was there another?
Yes, there is another question for Katarina that takes a different perspective. The question is from Nina Tusch, one of our DIYAPS voices. She asked, Katarina, how do you think that the advent and the reimbursement of commercial closed-loop systems will affect the DIYAPS community? We've kind of touched upon this earlier today, but go ahead.
Yeah, thank you, Nina. I think both worlds already influence each other in the best way possible. So the approval processes of many of the commercial AID systems, that has for sure been accelerated by the open source AID community. But we've heard a lot about access today. So not everyone will have access to a commercial AID system. For some people, AID is not available at all. For some people, it will be the only way for them to use an AID system to DIY it. So the reimbursement of commercial systems will provide more choice for some, but not for all.
And
question. Oh, okay. We might go here first. Thank you.
Levi from Israel. I'm a pediatric endocrinologist, and it was amazing to hear you, the community. But with the many options you have with yourself open access loop, we physicians are finding ourselves in a special condition where we cannot help our patients. They are using many kinds of do-it-yourself systems, which we do not understand, we do not know. The official sites, I have been through them, I don't understand exactly how the algorithm plays. And if you think that every child who is in a do-it-yourself system is controlled, it's not. So we are now in a situation that we have to guide our patients, but we not have enough information or education or knowledge. And I find it not enough with whatever it's going on the net, on the community, because we didn't tell our patient, okay, it's not legal, so we won't treat you. We told them, if it helps you, we're happy to go with it, because you are living with diabetes, we don't have better options to offer you. But now we cannot offer them the optimal thing. We have many patients do-it-yourself facilities. They don't know much about the net. We are in the Middle East, and they are not controlled. They're having high numbers and then low numbers. We don't know what to change in the system, and what the community is going to do to solve our problem now with this sophisticated problem.
Okay, Kati, I'm going to throw this to you, but I will just also say the burden of diabetes is so huge. Are we now adding to it that we have to solve problems for health professionals on top of everything else? Kati, fix this for us, please.
Yeah, sure. That's a difficult one. You said you're not sure how to guide the patients. Let the patients guide you, because they have all the lived experience with that. And if you spend time with us people from the WeAreNotWaiting community, you know we're willing to share. And it should be a bilateral dialogue, right? So hear their stories, maybe ask them about their learnings, and if the documentation on the internet is too complicated to understand, don't hesitate to reach out and have them break it down for you. That's how we all started our DIY journey as people with diabetes, and I'm sure will be feasible for physicians as well. Saying this as someone who's both.
And can I also point out that we are having these conversations at these forums now, and have been for quite some time, and very much the people who are educating here are people like Dana Lewis, who has spoken at so many conferences about her experiences and what this means and the technical side of things. I would advise that if you see that on a program at a conference and you are privileged enough to be at a conference, go to those sessions. Go to the sessions where there are people with diabetes. And I know I am preaching to the converted because you're all here right now, but tell your friends, tell the ones who aren't here. And I know that there are often clashing sessions that are all important, but I will say this until I'm blue in the face, and it is the hill that I will die on. The most important people that you should be listening to are people with diabetes. So when they're standing on a stage, go and listen to them. It's an easy way to actually hear and learn. Yes, hello.
Hello, yes. So first of all, I'm going to apologize for my English is kind of rusty. So I wrote my question in the translator, and I hope I can get the message straight. So first of all, before my question, I would like to congratulate all of you because of your remarkable work. I also have type 1 diabetes. So from the community, thank you very much for the hard work you're doing. And precisely, my question is, taking into account the elephant in the room, which is access and the budget and the economic terms, how do you suggest or recommend justifying this type of option in economic terms to the decision makers? Like, if you have any studies, I know Dr. Braune has some studies. I researched a couple of them, but if you have some studies that can justify this option as available for a national health system. Thank you. My name is Bruno, by the way.
Thanks, Bruno. Also, can I just say your English is perfect, and as somebody who speaks one language only, I'm astonished. Okay, Katarina, I am astonished constantly. Katarina, sorry, I'm throwing it back to you again.
I can only agree with you. Access is just as much of an issue as I said earlier. Now is the time to look into personalization, just as important. And I think this session and every of the talks highlighted that a little more. And it does not matter from what person that perspective is coming. Access and availability, always an issue.
Thank you. Great. We asked a question this morning at the open closing conference, and I'm going to ask it again because I think it's really important, and I'm going to ask everybody on the panel, including you, Bastian, to answer this, and that is, actually I'm going to ask it in a minute because we've got a question down the back. How's that for suspense? Hello.
Hi, can you hear me? Yeah.
Yes, but speak louder.
Hi, I'm Lauren. So I'm a hybrid as well. I really like that term. So I'm a healthcare professional. I'm a doctor in training in the UK, working in adult diabetes, and I've lived with type 1 diabetes for many years as well. So I guess I've got two questions for you. So the first is, this is an incredible online diabetes community, but I wonder what the representation is like within that community. You know, what proportion of people with diabetes do you think you represent, and do you have any data on that? That's the first question. And the second question is, you know, the patients, people living with diabetes I see in clinic, you've got the kind of top 10%, those sorts of individuals you're talking about that come from a 7% HbA1c to 6%. They're the top league, if you like. But then you've also got that the other 10% also who really struggle. You know, they're individuals that live with a HbA1c over 100 millimolar or 12%. And for those patients, the technology is just not even in the stratosphere. So I wonder, what can we do to support those individuals who really do struggle with diabetes and are at the most risk? How can we enable access to open source and looping for those individuals?
Okay, let's start with there's a lot to unpack, so get comfortable, folks. Okay, Hamidah, I'm going to ask you, if that's okay, to start with this question specifically around how is it that people with diabetes who are struggling, but even I think people who might not necessarily be struggling, or you don't know, but how can they be supported? What sort of things can health professionals do, and can others in the community do to support people?
Well, I think some of the solutions that you can have to have access for people from different parts of the world, like Africa, Uganda, is first of all having devices that can be compatible to the living situations. Like, for example, electricity, where in Uganda it is very common that you will have electricity in the morning, and within a few minutes, power will be gone. So how will you be able to charge your CGM when you don't have power? And another thing is focusing on the social challenges, like poverty, having education, whereby the warriors themselves that we support, or the warriors that we work for, have an opportunity to have education, live gainful lives, whereby in the future we can see them being able to support themselves, because at the end of the day, you're going to give a warrior a CGM or a pump. Are they going to be able, you can't have a CGM, you can't have insulin when you don't have food. So focusing on the social challenges and having devices which are compatible to the living conditions of the warriors is really a good solution.
Thank you. Bastian.
As we're just talking about this, there's a whole number of comments and questions towards you and your foundation and your work, and we won't be able to address all of them, but there are some comments about, great to have you here, we need to make sure that there's more voices from the African continent coming here. We already said in the beginning we were supposed to have 2 more voices from Africa joining us here. They were both denied a visa. We are very, very sorry for that. We hope to improve our work on the dedoc side as well. But there's one more comment here that I do want to pose to you, because it's coming from someone in Uganda following live through Facebook. And his name is Ivan Muzeyi. Ivan? Live from Uganda, he says, what alternatives have you been able to use to solve some of the social determinants of health, like illiteracy and poverty, that you have been addressing? So what approaches have you been taking to actually work with that, both personally or through your foundation?
7 years ago, when I started my advocacy journey, I was 18 years, and I was given an opportunity to attend one of the camps that we have held in different parts of Uganda. Through these camps, we reach out to warriors from all kinds of backgrounds. We sit with them in a camp of like 4 days, and we get to find out some of all these challenges. And one of the challenges that we found out is the distance that the warriors themselves have to take from home to the clinic. Some of our warriors have to travel for more than 5 miles to get to the clinic. Mind you, without food or sure whether I'm going to get something on the way. And some of the solutions to that started in 2020 when COVID came in the country, and we managed to come up with a project known as Project Boda Boda, and it has been able to serve more than thousands of warriors in Uganda, where we facilitate them with transport refund from where they stay up to the clinic, such that they can either get something on their way to eat and to reduce on the burden of the distance and what they had to eat. There is another program which focuses on education, and I am one of the alumni who are part of the program, which focuses on basically educating warriors such that they can be the advocates themselves, the ambassadors of their own lives, in order to be able to reduce on the challenges that lead to reduce on the death rates of young people in sub-Saharan African countries are estimated. You cannot live more than 1 year in sub-Saharan African countries if you don't have access to all these things that you need as a warrior. Yes, and with quite a number of things, personally as a person, I was able to hold a campaign in Uganda where I focused on creating awareness about type 1 diabetes in schools, and I've been able to attend different workshops and conferences to collaborate within different partners in Uganda and with the organization, taking my studies and research to Malawi, and to find out basically the challenges, the mental health that involves living with type 1 diabetes as an African person. How do you stay connected? How do you stay empowered? Because there are quite a number of challenges that can lead you to break down in very many cases. So that is when I started my YouTube channel. Actually, the conference inspired me to come up with a channel where I can bring people closer to the realities of living with diabetes in Africa. So everyone who would love to follow the journey, you can subscribe to the channel. My username is @AfricanDiabetic. So for anything and any updates about the news and everything about diabetes in Africa, anyone can be tuned.
Brilliant, thank you. We've got a question here.
Hello.
That's on.
Hello, everyone. I'm Sahil Madan, and I'm from India. I've been living with type 1 diabetes for 11 years, and I have been working as a HCP as well with a German company for 8 years. And I think we have talked a lot about tech access in different countries. Specifically, now we're talking about India, Pakistan, and other Asian countries as well. Being on the both side of it, living with type 1 diabetes and being a HCP for almost 8 years, I think what we need to understand is that when the tech is developed, it has to be adapted according to the economy of that particular country or the access. For example, in India, we have a lot of pumps available, but again, if we compare how expensive they are, whether that support is available, whether it's available in India or not. So that is one thing where it has to be, I think someone asked that question from behind. I think this is the answer for this being on the both side of it, and how we can actually start something which can actually lead to better adaptation of these tech in smaller countries as well.
Thank you. Thanks. Does anybody want to make any comment on that comment, or Kati, did you? No? Yes, go.
Yeah. Call to action at all the pharma and industry at ATTD. Please consider making your stuff more affordable and widely accessible. And just to comment on that question, how can you support people that struggle? as a healthcare professional, don't judge them. Give them time to talk and listen to them, what's actually causing them stress, because that might be multifold. For some people, it might be the availability of tools. For some people, that might be purely out of stress. For some people, that might be knowledge that they don't have. So try to identify with them, not for them, where the deficit is. And if it's stress, then consider getting a psychologist involved that knows about type 1 diabetes. So just a couple ideas. And finally, peer support. It has helped me, it has helped, I see the nodding faces and the smiles. It has helped many people in the room, and I'm babbling and getting over time, so I need to stop, but yeah, all of these.
If I could just, I'm not supposed to speak as a speaker, but one comment from my side to that question that was just raised. I think what we will be seeing moving forward is the DIY community, the WeAreNotWaiting community has been very, very strong developing these algorithms. We will see moving forward the DIY community or even also moving into the hardware space. And that is tricky, but it is going to happen sooner or later with 3D printing and all of that coming up. So there's some exciting developments coming up that might not be industry driven, but again, that may be driven from within the community. That's number one. The other thing is, one of the challenges coming up when we talk about mission accomplished in the WeAreNotWaiting community versus what's next is how can we use just the algorithms to improve therapy for those that might not have access to a sensor and a pump, but that might just be on MDI, but improve MDI therapy by using algorithms that are free of charge. So those are not the best solutions as we are used to here, but they will hopefully be improving quality of life and therapy outcomes for people living with diabetes without the need to access to hardware that is just not affordable. Because let's be honest, we all know that some of this hardware will not be around in low developing countries for a long, long time. So what we need is we need to find low tech, not low tech, but low cost solutions that we can scale up, and software is the easiest part of that.
So we've been talking a lot about how the community, so much of what's going on is being led by the community. So that was what Open was looking at, it's what Dawn was speaking about, we've discussed that. And one of the other big conversations in the community is around diabetes stigma. And I just want to touch on that momentarily because I'm interested in what the panelists have to say about the intersection between access and stigma. I've got 2 minutes apparently, so when I say what the panel has to say, I'm going to ask Minou to contribute here because you haven't said anything. But where do you see that interplay between access and stigma?
Access and stigma. Well, actually I find it hard to reply to the question.
I've put you on the spot. So if there's anybody who wants to jump in there, yeah, if there is anyone, because I think that this is part of, I think we touched on this earlier today a little bit, but are we sometimes putting the horse before the cart before the horse, whichever way it's not meant to be. I'm jet lagged, where we're focusing so much on access, which is important, but we've got to also get to the point where we're understanding what some of the barriers to individual access might be, and that certainly could be the stigma of diabetes. Am I just going to stand here and talk about this? Dawn, have you got something to say about it?
I think one of the biggest issues with access is the fact that when you have the technology, it is attached to you 24/7, and while that is a blessing in itself, it's also a burden. And I'm sure that most of us who've access to any style of glucose monitor that we wear or insulin pump that we wear have been told at least once that that's our diabetes cured. There seems to be a belief that that's the fix. And there's, on the flip side of that, there's also the embarrassment, the cringe that goes with having access to that technology and sharing a space with others who have type 1 who don't have access by virtue of their geographical location or the country they were born into or the finances which are in their bank account. And I think that's incredibly unfair and incredibly disempowering for both sides.
Thank you. I know that we could keep going with this discussion, but there's a lot of people outside who either want to come in or want to drag us somewhere else, and I know that there are ATTD waits for no one. Thank you to everybody for being here and listening. Don't go yet. Bastian's still got final words. Thank you for the questions and for people watching at home, and I'm sorry that we didn't get to everything, but I'm going to go sit down now. I'm done. Good. Thank you.
And thank you, Renza. Thank you, Renza, for facilitating this panel and taking the questions. There is a lot more that came in through Facebook Live and on the ATTD app, and I'm sorry, as always, that we never get to all of them, but this is the nature of a symposium like this. However, we have something in store for you if you enjoyed this. First of all, thank you for coming. Thank you for coming. Thank you for listening to our DDoc voices, for joining this symposium and taking in this different perspective that is not the most common here at a conference such as ATTD. We are very, very thankful that we can be here for the 4th year in a row now. If you would like to meet more DDoc voices, enjoy more of these kind of presentations, mark some of these events that we at DDoc do, I will start with Doc Night because that is something you can enjoy in person, those of you here in the room while you're here. In good DDoc tradition, on Saturday night, if you're still here, we have rented a full, very cozy Berlin nightclub in the center of Berlin, and everybody is welcome to join. You do need to register on the DDoc website, so go to ddoc.org/docnight. Tickets are free, or rather we say pay what you want. There's going to be free drinks, there's going to be good music, there's going to be all of Team DDoc and the DDoc voices, and whether you want to dance with us, just enjoy a drink, or meet and mingle and talk to more of these DDoc voices, please join us Saturday night. And then the other events, I'm not going to go through all of this in person, but we have our virtual Doc Days. The next one is coming up on March the 30th. We'll have a lot more DDoc voices and advocates from around the world presenting. And then we have DDoc voices again at the German Diabetes Conference, at the ADA in San Diego, at Friends for Life in Orlando. But we also have another Doc Day in German language. If you speak German, you're welcome to join us June 1st. And the biggest Doc Day a year we have is, of course, on World Diabetes Day. With that, this is the Doc Night logo, by the way. You're invited to join us, as I said. Again, thank you very much for coming. Thank you to all of you for being here, presenting, and thank you to all the DDoc voices here at ATTD. Enjoy the rest of the conference. Bye-bye.